Welcome to San Antonio, Texas. We're here at the American Association of Neurological Surgeons national meeting. We have our first interview outside of the STEIN headquarters. We've got Dr. Kondziolka here. I'll go into him in a moment. You know, it's a little bit lonely without Dr. Clausen here, but I'm holding down the fort for this interview. And the next one, so Dr. Kondziolka is the editor-in-chief of the journal Neurosurgery, but before that, and ongoing, he's been a very large innovator in our field. So I guess the first thing we always ask our guests, first of all, this society is the Society for Technology, Engineering, and Innovation in Neurosurgery.
Looks good.
We started as
It's empty.
It's empty. Wasn't last night.
Right, there you go.
Well, this one was empty last night,
Okay.
but the others weren't.
Yeah.
So at our national meetings, we have been having this gathering of geeks of neurosurgery. And we expanded this to it was the Society for Technology, Engineering, and Innovation in Neurosurgery. But we started a podcast where we have a neurologist and I do it together.
Yeah.
My close colleague who's a computer scientist and movement disorder neurologist, Brian Clausen.
Right.
And we have guests who are scientists, engineers, some people from industry, and clinicians as well.
Yeah.
We usually start by asking people how they grew up and how that shaped their path into science and neuroscience.
Well, I grew up in Toronto, Canada, and there was no physicians in the family, but my father was an electrical engineer.
Okay.
And in fact was sort of responsible for bringing the metric system into Canada in the early 1970s.
Which was done successfully.
Right.
It was not successful in America.
That's right. So that was one of his roles. My mother was a teacher. So science and education were sort of a theme.
Yeah.
And I went to the University of Toronto, and like true Canadians, we don't go away to college. We sort of stay as close as we can to home.
Sure.
And so I did medical school at the University of Toronto, residency at the University of Toronto, and then went to the University of Pittsburgh.
In medical school and residency, do you have any side jobs or hobbies that you do?
Yeah, I mean, one of the things that I worked in a garden center for a long time, and then my first summer of medical school, somebody came in that I knew. I played hockey with his son.
Okay.
And it turned out he was the CFO of one of the big sort of private community hospitals. And he said to me, "You're in med school, right?" And I said, "Yeah." He says, every summer we hire 2 med students to work in the OR as scrub nurses.
Oh, cool.
So the scrub nurses can go on vacation. And we'll just train you how to be a scrub nurse. And I said, "Great." And so for the next 2 summers, the first year all I did was pure obstetrics and gynecology. Then I did orthopedics the next year, and then that was the foray into surgery.
Okay.
And at that point, I knew how to sew. I knew all the sterile technique. I knew most of the instrumentation.
Yeah.
Before I even got to the end of med school.
Yeah.
So that was a pretty significant way to hit the ground running in a surgical residency.
Yeah.
So that was a lot of fun.
And you were a resident in Toronto, or you moved to Pittsburgh for
No,
residency?
I was resident in Toronto, and then I was looking for how to define myself in a different way. And my chair met with me and said, "So what are you going to do?"
Who is your chair?
His name was Alan Hudson, who was one of the top peripheral nerve surgeons in North America, and he just said to me, if you're going to be a vascular neurosurgeon, for example, he says it's going to be 20 years before anybody cares what you have to say about basilar aneurysms.
Yeah.
And so you've got to find a niche that is open.
Yeah.
And when I was a 4th-year med student, I went to Mass General, and I was introduced to what I like to call some of the crazies of MGH neurosurgery, which were essentially people doing some fringe things. For example, there was Ray Gelberg, who ran the Proton facility, which was the only radiosurgery game in the United States at this time.
Okay.
And he had a waiting list of the world's worst AVMs. And I thought, my God, this is incredible.
Yeah.
And then I worked a little bit with Tom Ballantyne. He was the last guy in the country still doing psychosurgery after all of the ethics issues of the 70s. So I saw that.
Was he doing
he was doing
Was he
singulotomies
doing the ice pick thing? Or was
no, but he was doing RF singulotomies for depression, and Bob Martuzza would do the cases. And I worked with Bill Sweet, who was, the old guard of pain management, and he showed me how to do percutaneous rhizotomy. And so when I went back to Toronto, and this as a medical student, and I hit residency, I knew about AVM radiosurgery, I knew about behavioral neurosurgery, and essentially my practice became all that fringy stuff. And I went to Pittsburgh to pursue a stereotactic and functional fellowship because at the time, this was the Renaissance, when essentially all the Parkinson's patients, the tremor patients were not doing so well on drug therapy anymore. Yeah. And it was time to start rethinking about the role of surgery. And Lori Lightnin had published the first work on pallidotomy, reinventing Lexell's pallidotomy, and that started getting attention. And so I wanted to get, I trained with Ron Tasker in Toronto, who was, sort of the man of the thalamus. Yeah. And so that was sort of my foundational knowledge, but I wanted to be a lesional stereotaxis, not just a functional stereotactic surgeon. I wanted to do tumor stereotaxis, because image-guided surgery was just developing with computer technology. And the University of Toronto, the first image-guided navigation system came out, which was the ISG mechanical wand. And if you recall this was a six-jointed robotic arm. Before, right now we use optical sensors to, locate the head and for navigation. Sure. But before optics, it was mechanical. Yeah. So we would understand 3D space through an arm attached to the table, and we could point. It was a mechanical pointer at the skin and at the tumor. It was actually developed. It was the PhD of one of my co-residents, who worked on axonal graphic visualizations. This company gets started. The guy never finished residency. He just went into industry. Yeah. And we never heard from him again. And that became the ISG wand. And the story of image-guided surgery follows from that. So that's the environment that I grew up in.
Did you do a PhD?
I did not. I did a master's degree in radiobiology. Okay. So I went to the University of Pittsburgh, and I realized radiosurgery was going to take off. And so I wanted to become not just someone who knew how to do it, but understood the biologic principles.
And so the radiosurgery of Mass General, that's different than what you guys did.
Yeah, this was protons mostly for AVMs. They did like one AVM a week, but in Pittsburgh we were expanding into vestibular schwannomas and meningiomas, and we had one of the first comprehensive skull-base centers in Pittsburgh. So we had a lot of leftover meningiomas and AVMs. Interesting, not many metastasis. Focal treatment of brain mets was considered heresy at this time, because if you had, the dogma was that, metastatic cancer was a diffuse disease, and it made no sense to do point-in-space surgical manipulation.
Yeah, they were getting whole brain.
We're getting whole brain. You needed comprehensive management, and we proved that was wrong. And in fact, 10 years later, I did the first randomized trial to prove that was wrong. Yeah. So, and then now that's the #1 indication in the world. Yeah. But at the time, that was very fringe as well.
Yeah. In Pittsburgh, you guys brought in really things that have been developed pretty recently at Karolinska, right?
Yeah, there was two things. Dave Lunsford had done a fellowship at Karolinska. Yeah. And so became close to, with Lars Lexell and Eric Backlund, who was doing, radioisotope injection into tumors, into craniopharyngiomas. But Dave put the first intraoperative imaging system in the world in an OR. In 1983, put a CT scanner, a GE scanner in the operating room. And people were, why would we do this? Well, now we were doing all those cases in an intraoperative CT environment, so we felt confident about deep brain targets. We could image right away. That eventually got upgraded years later, but that was step one. And then step two became the installation of a hospital-based radiosurgery system, which was the Gamma Knife. And that was not a trivial thing, and that's been well reported, that whole story.
You sort of systematically went through different indications for radiosurgery during that time. Was that following? Something I think about is I have particular interest in things like brain-computer interfaces. I work with a neurologist who runs the ALS clinic at Mayo, and it happens that he has a large patient volume that already comes to Mayo, and so in that sense, there's a need that we can address that's already in place. But another thing you can do is you can develop a practice, and then people come to you. And I know that, you currently have your referral base is the world, right? Yeah. For what you do. Did you start out like that? Would you start out addressing a need, or did you say, I want to target this indication and then bring the patients to me?
I think it was a bit of both. I mean, we built a team that included an excellent radiation oncologist and a fellow named John Flickinger, who also had serious bioepidemiology and statistics background, so he became the data manager of the system. We had a prospective early generation data collection system. So quickly we had something to say. And I have to say that, here we are at the AANS meeting for probably 5 or 6 years in a row. We had a talk every Monday morning in plenary session 1 about what we were doing. People wanted to hear about it. And to be honest, people wanted to shut it down. This was not well loved by everybody. It's like, oh, yeah, accept his abstract.
Because it's taking away craniotomies?
Oh my God, that's right. Let's put him on the podium and so we can rip him apart.
Yeah.
And then, a discussant would come in and say some things. And I remember 1990, I presented the first 50 meningiomas with 2-year follow-up. And the results looked pretty good. We didn't say they were great or anything, we just said pretty good. And I think the audience started to get the point that, wow, I would have reoperated on that and it might not have gone very well. And here's the patient went home the same day. And maybe there's a new way to be thinking about these things. So I think one of the things we tried to do was publish quickly. And that's what the Swedes had not done from Karolinska. Their philosophy had been to collect, we're not going to publish this until we have a real amount of long-term data. Our philosophy was get the word out on an ongoing basis. Let people know what we were doing. And that built the referral base. So suddenly sharing the data, people were willing to send patients to us because they knew the data was being tracked and was going to be published.
Yeah.
And I think that they sort of started to partner in the intellectual growth of the field. And I think that's a key thing with innovation, is to share the data quickly and so others can test it and not just yourself.
So that's kind of interesting. I mean, I'd like to get back to your role as an editor in general in a little bit, but for the journal that you have now, and there's a whole, there's a family of journals in neurosurgery. Are there types of manuscripts that you try to accelerate, or is there a particular pathway that you guys try to take to get things through that you think are timely?
Yeah, there's a whole sort of literature on hot topics in science or hotness.
Yeah.
There's a great article I think in Science a couple of years ago on this, and even on investigators. Investigators like yourself have hot streaks.
Yeah.
And you sort of catch a wave of a topic that everybody cares about, and you can ride that wave, and then it flattens out as others get involved, and the science slows down a little bit. So as an editor, I think a lot about that. And you might say, what are the hot topics right now broadly in neurosurgery? Well, for the last 3 years, something that would have been considered nonsense 10 years ago is very hot, and that's middle meningeal artery embolization for chronic subdural hematoma care.
Yeah.
And so now there's a huge literature on comparing different agents to do that. How do you do it? What happens if you're on antiplatelet therapy, with or without? When can you restart it? What's the need of drainage plus, embolization? These are all the different dynamic questions. So, when some new information on that hot topic is sent to us, we take it seriously and try to get it out there. And we're riding that wave as well.
Yeah.
And then certain topics, we sort of I'm interested as an editor to create the wave.
Yeah, so, you're in a position to do that.
Well, that's right. So, an article might come in and I'm looking at it and go, whoa, these people are really thinking differently. And you might say, I could put that aside, or I could say, let's run with this a little bit here. Because I'm sure, same thing with you, one of the most interesting elements of my practice and career is when something unexpected happens.
Yeah.
Things that I love is when, a med student or whatever comes into my office clearly with some idea that I hadn't thought of, and they want to run with it. And I might have the data, available to answer some of that stuff. And I'm saying, yes, let's do it, right?
Yeah.
And the next 3 years is sort of a new side angle that I never even thought of. And that's the fun stuff.
Yeah, I have this, he's now just finished his PhD a year ago, and a student his name's Michael Jensen. He'll be coming through the trail pretty soon.
Yeah.
You know him from the stereotactic
Right.
papers we did together. He wrote
Right.
those. Those papers were his barrier to entry into the lab. But we had this moment where he came in, and I'd asked him just to look at, we would do stereo EEG, right? This is a new thing that it's been around, but people haven't looked at it as much as a neuroscience tool. And so I just asked him to look in the, basically in the anterior bank of the central sulcus, posterior bank of the precentral gyrus. We expected the topology of sort of somatotopy to be preserved there. We know out in the convexity that there are premotor areas along the sort of Brodmann area 6. But he came in and he found, in addition to somatotopic areas, he kept getting these areas that seemed to be active when you moved or when you talked, and regardless of the side of the body you're moving, down in the depths of the sulcus, and sort of broke our standard way we think about the homunculus. And he said, he came in as, this is a problem, what did I do wrong? And I responded to him with, I think this is a problem, I think you probably did something wrong, but let's chase it. And his diligence, he then pounded it through, 12 different patients initially, and then we got more where he looked at it and this phenomena was preserved. And so that was kind of fun, and then we chased it. Of course, the problem that we had is that we had, he gained this technical expertise, I have this expertise, but then he had to go back to medical school, and I have all the other projects. But this has gained a lot of traction recently because there's this group at WashU looked at resting state MRI around the same time, and we called our areas the Rolandic Motor Association areas, association area in the depths of central sulcus. But these guys in WashU found interactions between primary motor cortex, or what they called primary motor cortex, but a lot of it's probably out on the bank of the precentral gyrus, but they thought it was integrating sort of, they call it the somatocognitive action network. I don't know if you've come across this, yeah. But this has sort of gained a wave, and there's this group, this imaging group that's been really good at communicating in a way that, I don't know, at some point in my career I'd like to be able to do that, because we had similar findings, but just didn't have the large set of people you need to really push these things forward.
Yeah. Well, one of the most fun things in innovation is not only to tackle something unknown, mm-hmm. but to question something that people think is known.
Yeah.
And, neurosurgery, as an example, is full of dogma that is, in my opinion, probably wrong. And I always like to think, 100 years from now, 50 years from now, what things do we right now, and I was thinking of writing an editorial about this, what things do we think are absolutely true, or I'm asking people about this, that in your career turned out to be wrong?
Yeah.
And if you think we're such an image-guided specialty, neurosurgery, like technically, stems out of neuroimaging for the most part.
Yeah.
We operate on something because we see disease and we understand it from that. So a lot of the understanding came from lousy imaging.
Mm-hmm.
I mean, how do we understand parenchyma before 1975 and CT, or even 1987 and MR? I mean, a lot of the dogma is back from plain films or no imaging, which equals autopsy. And a lot of the lessons, for example, that metastasis are diffuse, that comes from autopsy data, not imaging data. I think it's very cool to think of, why do we think that's true? Where did it come from? And what are we going to do about it?
What do you think about, people talk about technology as disruptions. And in a lot of ways, radiosurgery disrupted craniotomies, focal resections. Right. I think it's a motif that I've seen in my career in neurosurgery has been sort of the disruption of mastery, right? So you had vascular masters
right.
who could, and then you have, in gliomas, you have the same thing. And we're appreciating the fact that, preserving KPS is maybe more important than extended resection for survival.
Yeah, that's a really great point. And a number of years ago, when I was president of the CNS and I gave my presidential address, I sort of talked about this, because we train people in residency to be technical masters. We want that to be achieved. But I've always said that mastery is not healthcare. If you look at the best people in the world doing some operation, when they retire, it's over. So we have to keep training. And it's interesting that, poor outcomes, let's say resection of vestibular schwannomas, well, you've got to go back to the cadaver lab, you got to try harder, you got to dissect differently, you're not a master yet.
Yeah.
The answer might be, that's wrong. I mean, Tylenol, we want Tylenol, surgical Tylenol.
Yeah.
You know, you have
Something
a
that
fever.
scales.
You have a fever. You take Tylenol.
Yeah.
It works. Works for everybody. It doesn't matter where in the world you are.
Yeah.
You don't have to go from Indonesia to Germany to get your acoustic neuroma managed if there's not somebody good in Indonesia.
Yeah.
That's not healthcare. So, what I call it, you know, the generification of surgery. People criticize the concept, and that's part of the reason radiosurgery got criticized.
Mm-hmm.
But the argument was to make this available, excellence available. And of course, who wants it the most? The patients want it the most.
Yeah.
Right? So radiosurgery ends up disruptive because the patients want it.
I think about this phenomena sometimes of, when we think about how knowledge came through the Middle Ages, you had these monks and monasteries that had beautiful handwriting. They would transcribe single books, and then they were masters of transcription. And then the printing press came along, standardized everything, and exploded knowledge in the Western world.
Yeah, Yuval Noah Harari's book Nexus addresses that story from the beginning of time.
Yeah.
And it's a great read if you haven't seen it. The transfer of information.
I think you told me to read that maybe 6 months or a year ago, and I haven't read it since. So I'm gonna
good for an airplane.
Yeah, yeah. What do you think about disrupting radiosurgery? So focused ultrasound, laser ablation, two things that I do some of.
Right.
In a way, those are disrupting radiosurgery in some contexts.
Yeah. In some degree. I mean, I look at this as, if you take a step back, what is the definition of surgery? Okay. And I made a definition a number of years ago, put it on a slide, and it was single session manipulation of a disease or organ system to deliver a specific outcome done in one session. Okay?
Okay.
Using energy.
Okay.
The last two words, using energy. And for hundreds of years, we've used mechanical energy. We've moved our arm to hold an instrument.
Yeah.
And, the last 50, 60 years, we've been using other forms of energy.
Yeah.
Radiation energy in radiosurgery is the first sort of understood, manipulable, and modulatable energy source. And so it naturally becomes used. Thermal energy, so you have laser or light energy and thermal energy, or focused ultrasound with thermal energy, or other forms of energy. It's interesting that thermal energy was used in the 50s and 60s with probes, and it sort of died for a number of reasons, mostly technical reasons.
Yeah.
We've gone the opposite, to cryo.
Yeah.
We've gone to chemical manipulation with glycerol or chymopapane or other types of things. So it's thermal energy. Thermal energy has its own unique properties. It took, certain imaging tools to understand how to map out the potential effect. And, but, for example, there are issues with its delivery technique. You can't do laser on 10 brain metastasis. It's just not going to happen.
Yeah, that's right.
You're not going to put 10 probes in the brain.
Well,
or maybe
some
someday.
might put in 4 to 5.
No, right.
Some people are doing hemispherotomies now.
Well, that's right. Or some people might do that.
Yeah.
Focused ultrasound has been okay in central brain targets, but not so much at peripheral brain targets, where a lot of tumor disease exists. Maybe that can be potentially overcome as a limitation. Radiosurgery is not perfect in radiation energy. All of these things have a role, is the point.
It seems to me that in stereotactic and functional neurosurgery, the thing that's coming is sort of techniques to rewrite the biology of the place where we have an abnormality, whether it's a circuit abnormality or maybe even some disease process using some combination of gene inserts with viruses, stem cells, and drugs, basically delivered stereotactically. Is that something that you think about as an editor of neurosurgery and as somebody who comes from functional?
I think about it a lot from the perspective of translational research. When I did some of the very first stem cell injections or cellular implants for stroke, this was in 1999, got a lot of attention.
Yeah.
A lot of the PhD community, not the clinicians, looked at this and said, you can't do this. We are not ready to put cells in the brain to, try to deliver brain repair outcomes. And so, but this is what neurosurgeons do. Our job is to take science, which we think is mature enough, and then do clinical research to test it. And so I often ask, do we really understand depression, for example, to be able to do behavioral neurosurgical manipulation? So when Tom Ballantyne was doing cingulotomies at Mass General through the 70s and 80s and earlier, we live in the present tense. He thought, and Freeman and Watts thought back in the 40s, that yes, we understand depression, and we understand schizophrenia, and we can do, frontal lobe transections and so on. So we always think we're smart enough, and then people look back and go, what were these guys doing? And so we live in, we're finally, and you have been a leader in this, we're finally entering the world of systems neuroscience, and not point-in-space neuroscience, where we, lesion, the subthalamic nucleus, because we hope that the downstream effects do this or don't do that. And we're starting to understand this at a much higher level. I love the fact that, in the 90s, through a number of, people who were leading, if you think of Parkinson's disease as the first neurodegenerative problem that was well understood, people talked about this. That's going to be the first one to be cured, and it should be cured pretty quickly, because we really understand Parkinson's disease. This was the 90s. Well, here we are.
Although if you have Parkinson's disease now and you had Parkinson's disease in 1985, you're doing a lot better now. We do have good therapies.
But if you had it now, compared to 1995, where we were doing not subthalamic stuff, but bilateral palletotomies. Let's take it to 2002. Doing subthalamotomies in 2002 versus now, are we doing a lot better? A little bit better.
A little bit better. Yeah. I mean, for psychiatric disease, something that I struggle a little bit with is this idea that there is such a thing as depression, or there is such a thing.
I love that question.
Because there's clearly a constellation of different different underlying conditions that have maybe some common common phenotypes that they produce, but even those phenotypes aren't are heterogeneous. And so,
what is trigeminal neuralgia, right? I love this topic. What is major depression? Yes, if you ask the psychiatry community, the definition of treatment-resistant major depression, which has been necessary to enter, neurosurgical trials, is evolved. It used to be failure of 4 different kinds of therapies. Didn't even matter what the therapies were. Could have been ECT, 2 drugs, behavioral therapy. Then and the outcomes are poor if you've failed 4 therapies. Then it was readjusted a little bit, and that's a very heterogeneous definition.
It is.
And if you think about it, it's no wonder that clinical trials have not been successful when the substrate is not so well understood.
Yeah. I mean, I think that, so there are groups that are doing interesting work in patient-specific network interventions, and for many of them, starts with stereo EEG, and then they find custom targets. There's Casey Halpern, and obviously I know the surgeons. These are big teams, and like the surgeon's little corner of that team that I know, but there's Casey Halpern at Penn and Samir Sheth at San Francisco, at Baylor, and Eddie Chang at San Francisco, who've all done some interesting interventions for these things. They are able to exercise individual judgment in order to do something new and different. But the amount of pushback they get in the modern world, where neurosurgeons are members of institutions and the institutions have say over what we do, seems to be very different than what you would have been able to do in the 90s. So our ability to exercise our own judgment, which is for each of us is different depending upon our backgrounds, but our ability to act with our own judgment seems to be increasingly impaired as neurosurgeons in every regard, right? So as scientists trying to bring something to our patients, but also, let's say, as decision makers in what surgeries are done, right? We have payer groups that tell us what we can or can't do. We have, if I want to use a device that at my own discretion, but it's only been it's identical in many functionalities to another device that went through a trial, but maybe it's a little more robust and has a rechargeable component. I run into institutional problems that my impression, and maybe it's just my impression because everyone thinks things were rosier previously, is that our ability to exercise judgment and our ability to act autonomously as surgeons is perhaps less than it was, 15, 20 years ago.
Yeah, I think there's 2 themes to that one. The first was, you sort of mentioned some of the behavioral work, and you mentioned earlier that we're we're a cog in a big program.
Yeah.
You know, we're the technical effector of neuroscience research, essentially. I've been personally disappointed in the psychiatric community. I mean, if you think of the tremendous need regarding major depression, OCD, other elements, you know, the young psychiatrists, the residents, the young faculty, there's not a sort of a new group who are neurosurgery friendly to the point of, you know, they're coming out saying, I want to do these trials with you. Like, who are these people? I don't run into them.
Well, I had a dear friend,
Yeah.
Nolan Williams, he was dual. There's this program in MUSC. There's a couple others that start with their dual trained neurology, psychiatry, and then he went into psychiatry. He pioneered short-term, meaning week or two, high-intensity TMS therapy.
Right.
And then some of these patients were then pre-localized to do neuromodulation with implant devices. Unfortunately, he died tragically in the fall of last year. But my hope is that there will be a new sort of culture of folks who come out.
I've been hoping for this for 25 years, and it hasn't happened.
Yeah.
And it's so fragile, like it's because somebody died, somebody retired. I can say at the University of Pittsburgh, we had excellent psychiatry collaborators. I had psychiatrists in the operating room. I mean, it was a great place to be doing that kind of work. Serious NIH-funded folks. And when I moved to New York, that just isn't the case. Mm-hmm. And I mean, excellent people, but not with the interest necessarily in surgical translational research. They're doing great work in other things. But we're at the mercy of collaborators. And you know, you have to build a team, and it takes time. It takes time. Yeah. On the issue of, you know, insurance payers and innovation, it's a great topic. I wrote an editorial on, you know, who decides standard of care, written articles on with former resident Zane Schnurman, who is currently a fellow at Stanford, and is a real out-of-the-box thinker, and we wrote a lot about this. And I love when insurance companies deny me. Like the other day I was on the phone with some insurance company denying the treatment of brain metastasis, radiosurgery. And they were quoting, well, you know, the patient has 10 brain metastasis, and the data suggests that, you know, we'll only approve up to 4. And I said, well, I said to the doctor on the phone, I said, you know where the number 4 came from? He goes, no. I go, well, I did that study. Yeah. So I'm saying, you really respect my prior work, but you don't seem to respect my current work. Yeah. And I'm so sorry. And so then I told him about all this other stuff that he wasn't aware of, and then they quickly approved it.
I'm glad that worked.
But I think at a national level, and this is where I would go here as a policy statement, the public is demanding innovative healthcare solutions to their problems. Yeah. And there are those of us who have been committed to university-based practices and academic collaboration, and the fact that we publish our work. We should be treated differently. The innovators should be treated differently. If you have a track record of successful innovation, I think we should have a gold star by our names that insurance companies say yes to us.
That'd be a dream, yeah.
It would be a dream. But can you imagine, why wouldn't they? And if you showed that in, let's say, 5-year epochs that you continue to be a successful, productive investigator, you continue to get the gold star. If not, you lose it. And why would the public not want this? They would want it. I'm thinking about this problem.
Well, what the public wants, and then what payers want is not.
Yeah, but the payers are, you know, they need help.
They do. I agree. And I hope that we can have, you know, advocacy groups in neurosurgery and maybe communicate those with.
I mean, we're talking about innovation today. So one of the key elements is, you know, how do you make it a reality? Not just it works, but people are going to pay for it.
That's. I mean, in my mind, that comes from. That comes from 2 places. One is that you think that an innovation is going to make healthcare process more efficient, and I come across this with lasers all the time. Yeah. So I can do a intervention open, or I can do it with a laser. And because of the realities of the way the industry works, oftentimes the upfront cost is higher with laser, and that's its own thing. But the cost that you save by having somebody go home the next day compared with being there a week, and there are times when open is better, and there are times when probably laser is just as good. But if they go home the next day, that saves a lot more money. So that's one argument. And then the other argument is that the motivation for all of everything that we do has got to be beneficence, right? And increasingly in a system of, let's call them healthcare organizations, payers, and physicians, the physicians are crowded into having to make arguments less and less that are based on beneficence and more that are based on system efficiency and acting in the as let's call it service providers rather than as physicians. And I don't know that that's a dial that can be turned back. I don't know what you think about that. But.
Well, I think leaders lead, and
yeah,
we have to develop leadership skills, policy skills. We need more physicians in Congress, for example, and so there are avenues. This is very slow, but cost effectiveness research is something that, when it's done well, can be very powerful.
Yeah.
As an editor, one of the problems is it's not done very well very often, and of course costs are a vague thing. We know charges. We can always get charge data.
Yeah.
But not frequently cost data unless you really partner with a hospital to understand such things. But if you can get it, you can be disruptive.
Yeah. Well, and from a systems perspective, an acute intervention, that means that you don't need a medication for life. Yeah. It's going to cost a lot more up front, but save a lot more in the long run.
Well, if you look at what Elad Levy's doing in Buffalo right now with his group, they're really interested in outpatient-based or ambulatory care-based stroke care on procedures that you might say, well, you have to do that in a hospital. There are different endovascular indications, and he's showing equivalence in safety in a non-hospital setting. This is a disruptive,
cost-changing. When you say non-hospital setting, is this a endovascular rig in a truck that they drive somewhere?
No, it's at an ambulatory care facility. So
okay.
The doctor's office,
okay.
keeping people out of the hospital. And in a suite, just like many other minor procedures, plastics, other types of things are done. Can neurosurgery ever enter the world of minor procedures? Of course, it's happening in many different elements, spine, other types of things that we do. We sort of cherish the nervous system, and we think a lot about the N of 1 complication that would be a disaster.
Yes, yes, we do.
Right. So, there's work to be done on that topic, but at some point you got to break down the barriers. Just when they said radiosurgery is not going to work.
Yeah. Well, radiosurgery. I mean, there's Dr. Adler. He was a mentee of yours, I guess, in some capacity.
No, he's just no. No, I don't even know what that means. He's a longtime friend. Let's just call it that.
Yeah, when I was a resident, he would have my wife and I over with our kids when we were small, and we'd talk to him. But he has this idea of bringing radiosurgery sort of, I don't want to say bring radiosurgery to the strip mall, but really making it so it's portable, where you have these portable devices that don't require.
I mean, he really believes that radiosurgery use is underpenetrated globally.
Yeah.
And he's trying to break down the barriers for access to the procedure, not just patient awareness, but a system that hospitals could afford in different parts of the world, so that more people can have this. That's his vision.
Yeah. There's a completely non sequitur, but the same thing is kind of happening in nuclear energy right now, where they're designing small reactors that can go places rather than these large, 3 Mile Island kind of facilities. There's, our thoughts about nuclear energy are based on the 1970s, and turns out technology has advanced a little bit since. I think switching gears for a moment, back to sort of your own story. You don't become the editor-in-chief of Neurosurgery overnight.
Yeah.
And the life of an academic neurosurgeon, in some sense, runs parallel to the life of a clinical neurosurgeon. How did your academic life sort of bring you into this role? And
yeah, I think one of the things is that I got involved in organized neurosurgery, first through the American Society of Stereotactic and Functional Neurosurgery, and eventually I was president of that a long time ago, in 2002 as a matter of fact. But because I was on that group, Bill Friedman, who was the chair at the University of Florida after Roten, invited me onto the CNS Executive Committee. He was a stereotactic person, and he was sort of going off, and they wanted somebody who understood the stereotactic world, and so I became that person. And when you're asked for volunteer positions, what did you want to do? And I was I'd run the meetings. In fact, here we are in San Antonio. I was the scientific program chair in 2000 at the CNS meeting here. But I wanted to be on the publications committee. And so you start to understand journal dynamics and so on. And then when I was treasurer, I co-negotiated the journal contracts between the big publisher, which was Lippincott, Williams and Wilkins, and the CNS, and then a few years later negotiated the next one. And so now you start to understand the business dynamics of publishing. So, we understand the writing. We're all published, and we understand peer review to some degree.
But these are much different in the digital era, right? Neurosurgery is still in print.
Yeah. Right, but this is just understand how do you become an editor. You have to have a deep understanding of, I would say, running a magazine, okay, sure. Or running a family of magazines, which is a lot of different things. It's got to be a successful business. It's have to have quality. There's lots of elements to this. So I started step by step building the foundations, and then I started getting into software development for tools to improve writing and review. Sort of understood that well, and so then I was it was funny when John Jane stepped down as editor of the Journal of Neurosurgery. There was a search, and the 3 finalists for that role were Jim Rutka, who was chosen as editor, myself, and Michael Failings. And the interesting thing about these 3 guys is that we were all residents together at the University of Toronto.
Oh, really?
Yeah, so
I guess that makes sense.
Can you imagine that, 3 people out of the same training program from the same era, years later,
and none of them American,
right, had come to that type of thing, although I'm American now. And then Jim, when he took the job, invited me to be associate editor, and we served in that role for a long time. So a lot of this is stepwise understanding of being an editor. And one of the things about journals is that they are a key element to running an organization like the AANS or the CNS in terms of information dissemination, taking things at the meetings and putting them into print, but also helping to run the business of the organization as well.
Yeah, I've interacted with journals across the spectrum, from science to clinical medicine to neurosurgery. The mission of them is very different. The mission of the Neurosurgery Journal is not to entertain. They're definitely entertaining and components where you want to engage the readers. Yeah. But really, it's to help practice. Where do you think the sort of the service component and the engagement? I don't know that it needs to be called entertainment.
No,
where's the balance?
I think that's
there?
A good word, actually.
Yeah.
And I think there's 6 or 7 components, purposes of a medical journal, and here's one. One is to surprise. Yeah. Okay. And I love that term. One is to surprise. You open it up, you go, wow, I didn't know that. I didn't even know people were thinking about that. Yeah. So that's surprise. So that's key. One is to shepherd a discussion. So if you think, you have discussions in the hallway, you have discussions at journal club, you get people thinking about something, a dialogue. Somebody else will write an article about the topic. So you're fostering and shepherding a discussion. Of course, the classic things on information dissemination and so on. But so whether entertainment is part of that, but like anything, you want it to be sticky, you want it to be memorable. And when I look at a good issue, of course, things come out online, but when I look at the print issue, which is sort of a bound, archival element of it, and I flip through every article, some issues are particularly great, where I'm going, there's a quick take-home message, boom, 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 all the way along. Go, wow, this is just full of memorable events. That issue is, I think, really helpful to the specialty.
The take-home messages from individual articles can be short.
Yeah, right. And it should be short. Our memories can only handle short.
Should there be? I've had articles where the supplement goes up to supplemental figure 35.
Yeah.
Right, and the actual article has 4 or 5 figures.
Yeah, but that's, the message has to be memorable and short. The deep dive is into the other stuff. That's a different purpose.
Should the written journals, when we have them now, be more oriented as getting those key points across, but now basically always connected to a deeper dive digitally?
Yeah,
Should there be a 2 format for every paper?
Well, that's why we went to completely digital.
Yeah.
Because if you look at video content, supplementary digital content, the full article was online. The print article was a subset of the full article. So because there was so much supplementary content and video and other things, it didn't make sense to keep the print issue. It was an incomplete archive, in fact.
Yeah.
So, and initially I thought, okay, we'll do that, and then submissions will go down. They did not go down at all. If you look at neurosurgery, which the complete issue, a complete article for the most part can be in print. There is some supplementary stuff for people who want to do a deeper dive. And people have called for the death of print for 25 years.
Sure.
25 years.
Yeah.
And when I go around the country and ask people, do you read the print issue? Many people who are probably under the age of 45 say no. That's a general statement. But not everybody.
But some of them are reading tweets, and that's it.
Yeah.
I mean, they're reading.
Well,
if
that's
it's
right.
more than
And
a
so
paragraph.
I look at the content, and there's 3 formats. There's print, which I love for analog environments. I'm on an airplane or whatever, or I just want to feel paper. And there's a reason I'll talk about that in a second. And then there's the your standard digital content on a computer, and then there's mobile. And mobile, I use mobile a lot. And it's because I live in New York and I take a taxi to work and a bus home or a cab or whatever.
Yeah.
And so I'm on my phone reading articles a fair bit. And so the mobile environment is really important. I probably use that more than the digital, the classic. And the thing about print that's interesting for us, if you look at I spend a lot of time on the covers and the look and feel of the flow of the magazine. That if that goes purely digital, that's the cover, which has often been a celebration of what neurosurgery is every month, becomes a thumbnail,
Yeah.
And I don't like that thumbnail.
Yeah.
And it's suddenly bland, and all of a sudden it's just a bunch of articles. It gets away from the surprise specialness of this. And so I'm not in a rush to get rid of print there, because I think our specialty is a wonderful thing, and I like to keep that.
I mean, do you envision, I guess there's a few questions I want to ask, but do you envision that we could have a functional journal into the neurosurgery family?
Right.
But basically you had a family of journals, and then the print version really was not digital abstract, or not just graphical abstracts, but really this is what I think is important about what I found. Here's a couple images that describe it. And if and then that exists sort of as a printed magazine on top of a foundation that contains much deeper dive.
Yes, that could definitely, I think about, for example, further subspecialty topics.
But in the digital format, and then the best of them makes it into the print.
What we're actually working on right now is what I call video abstracts. So my vision is that every article, right now people often read the abstract. But if you're not reading, and let's say you're listening, like on a podcast, for example, there could be a monthly 40 seconds to 60 seconds per article continuum. You could listen to an issue in 20 minutes, where the author comes on and describes why they did it and what they did. It's the things you just said.
Yeah.
Which is essentially the abstract. Yeah. There's some logistical elements in here because that has to be peer reviewed. The author can't say something that isn't in the paper. It has to be, and we're working on a review process of this, and we're working on the software for this.
Yeah.
But
3 or 4 slides maybe on YouTube.
Well, that's right. And the CNS was doing this with one article like a month.
Yeah, I used to listen to those while I was running, actually.
One article a month. and it was put on YouTube and so on.
Yeah.
But logistically, it was, and I loved it. You know, I looked at it sort of as a beta test of what I wanted to do. They stopped doing it based on some hassles and so on. But software can overcome any hassle, and so I'm working on that.
Okay. As we think about article formats, a lot of journals have moved away from case reports. Oftentimes that first observation, a single patient, leads is what opens everything up. And then there's some other things. You and I have actually talked a bit about this, but this idea of there's a neurosurgical arms race where people publish as much as they can, but in the era of GPT software that is trained on the medical literature, you can generate a literature review article that is summarized and well-sourced and pretty good in 3 minutes that is not close to what you want, but exactly what you, or exactly within the scope of what you want. If those types of articles continue to exist in the literature, is it really just the connection to the expert? And if that's the case, then really it should only be people who've really been practicing this for a long time, not their medical students or maybe their residents writing these things.
Yeah. You talking about the case report, or you're talking about?
No, I'm sorry, I'm talking about the review article. The case report's a different thing.
Yeah.
Case report, I mean, we could have just easy repositories where you put it in. And
well, that's right. I mean, we're getting so many review articles, and my editorial last month in Neurosurgery was reviewing the review article. That's what it's called. You know, it's interesting. If you wanted to chase impact factor at a journal, you could just publish reviews. Yeah. In fact, some of the journals with the highest impact factor are like reviews in nephrology, like this kind of thing. So people like to cite that stuff. Yeah. But we're so inundated with these submissions that, and on some fairly esoteric topics, that if the review does not generate some new finding, like for example, the individual studies, you know, show this, but if you put them all together, it actually shows that. Yeah. We love that stuff. Yeah. You know, if it's more me too about some topic, for example, I mentioned middle meningeal artery embolization, you know, earlier. I would say there was a few months ago where I received probably 6 systematic reviews on the exact same topic within 3 months. Okay. Right? Everybody thought I needed to do a review on this. Yeah. And for a topic that hasn't been around very long. Yeah. And then sometimes the answer was no. You know, so sometimes I will also say to people, when you talk about the expert behind it, I said, you know, this is how I think. If you care that much about this topic, give us your own data. Why are you not giving us your own data and use the review as the benchmark and compare yourself? And then tell us, maybe you weren't doing so well, so you've changed. Or you were doing better and you think you're better because of that. But you know what? That takes work. And that does take work. Right. And if these review articles are just being done by medical students or others typing in some stuff, that requires very little work. Requires very little work in the era of GPTs. So I'm interested in fresh new information. So give me the review article, but show us what you got at home too. If you care about, and sometimes I'll even ask you, do you even do this procedure at your institution? Like I'll get something like, you know, the treatment of basilar aneurysm is using this, and you know, by some institution, and it seems a little like very specific. And my question initially is, you obviously care about this topic, but do you do it? Yeah. Like you mentioned, you know, the expert behind it. Does anybody even have any experience behind this topic? Yeah. So we have to ask these questions now as editors. Interesting. I remember Kelly Foote telling me about how he wrote an article that was essentially salvaging DBS systems that had come to him from elsewhere, and that made it so he was dealing with sort of, you know, 5 times the number of patients who had complications after that because of what he'd written. I love that article. Yeah. And I remember. But then all the people came to him. Well, you know what also would happen is that I think I had a patient who, you know, did okay for a while, and then they were, you know, having an issue or something, and moved to Florida, and they went to see Kelly and Michael Oken, right? Yeah. And now I'm thinking, are these going to guys look at this and say I did it wrong, right? Yeah. Which is, who's the arbiter? So anyway, turned out they said everything was fine. But yeah, well, you know, we live in a difficult profession, right? I mean, we all. I think about that sometimes, right? If I think my complication rates are low or whatever else, some of my patients may be going elsewhere and seeing my colleagues. And I think in our profession, you have to have a certain amount of arrogance to think you can tamper with the brain and get away with it. And that selects for people that do that. And then you select for high-performing people.
because you don't get into neurosurgery if you're not high performing.
Well, one of the things as well, one of the great things about international meetings is that, in the radiosurgery example, there was sort of dogma and that, based upon very little radiobiological information that, the optic nerve and chiasm, could take 8 or 10 gray. It's even a board exam question in radiation oncology and neurosurgery. And we are partly responsible for that. We wrote some early paper on some side effects, and we say if you stay below 8 gray, you should be safe, right? But then you go to Japan, for example, and I'm specifically, or other countries where they have a different medical legal environment. Like, we're conservative in a defensive medicine practice sometimes, but I went to Japan and I'm seeing they're giving 12, 13 gray to patients with craniopharyngiomas very right against the optic chiasm. And I'm going, whoa, I would never do that dose. And here's the results. The results were good.
Yeah.
No vision problem. Tumor regressed. And they're showing real information on safety beyond what I thought. And that made us go up in our recommendations. And, again, breaking down perceived dogma that came from very little.
Yeah.
Right?
Yeah. Well, I think the balance between confidence that you have to do what we do, and then humility to change your practice in light of new data. And that doesn't mean that what you did in the past was wrong. It was always just the best you could do.
Well, that's right.
With every opportunity you have. And then, something that I think about is sort of our vulnerability as surgeons, like being able to be vulnerable with one another when we're worried that we may come up with a complication, and calling somebody for advice saying, have you been able to get through this, get a patient through this safely? What did you do? Because we have to sacrifice our egos for the good of our patients. And
it's very hard.
It seems like an obvious thing to say, oh, everybody should do that.
No, but you have to.
It's difficult.
If you work in a great department with great colleagues, it's easier.
Yeah.
My advice, especially to people who are just starting practice, neurosurgery is hard. I love this, I say it all the time. This is not easy stuff. And you're going to have issues, and you're going to think about them. When I have a great result, I think about it for 5 minutes, literally. And then I go down the hall and see the next patient. I mean, it's literally some amazing results. It's 5 minutes. I have a complication. I'm thinking about it for 6 months or more.
I know.
I'm thinking about it on my way home. I actually lose sleep.
Yeah,
me too. This is my personal thing, and it's not healthy. And so, we need to, and for young people starting a practice, they can't, my advice is talk it out. And don't make decisions in a vacuum. You don't have to do that. Share the success, share the troubles, and you'll be better for it.
Yeah. I don't know if you remember this, but for those that are in the audience, when we take our neurosurgical boards, we present our cases. And you actually reviewed my cases in the boards, and that was good. I felt like you and your colleague who did that were fair, and I'm glad that I passed my boards. That was good. But one thing that I think is there's an adage that when you're taking your boards, you're never supposed to talk about a paper that you published. And I had the unique privilege of, I had this rare, it was Rosai-Dorfman disease in the spine.
Yeah.
And you said, somebody published this because you had published on Rosai-Dorfman disease in the spine. I thought that was particularly funny. It's sort of non sequitur for the case.
Well, as somebody who used to run the oral exams for the AANS, a lot of adages like that are nonsense. If you've written a paper about it, feel free to talk about it. Hopefully we can shut that one down.
Yeah. Yeah. Anything else you'd like to talk to our sort of general audience about?
No, I think this was a great discussion.
Yeah, I really appreciate it.
On a lot of topics, and really appreciate the time, Kyle. You're doing a great job. And,
thank you so much. It's wonderful to have you here. Yep. And we'll see you guys back in Rochester. So thank you. Thanks a lot.
Yeah.